Good evening, everyone. Thank you for joining us to the second LSRS educational webinar in the series. My name is Zorica Buser, and together with Dr. Michael Lee, we chair LSRS Education Committee. We are really very excited for our speakers and our debate tonight. The topic is what parameters drive the choice of surgical treatment for lumbar spondylolisthesis. And this is our agenda for tonight. Very brief introduction and followed by Dr. Ghogawala, who is taking position for fusion as a choice of treatment for lumbar spondylolisthesis, and then followed by Dr. Hah and talk on decompression without fusion. Both speakers, really excited to have both speakers who are experts in the field. And our discussion will be followed at the end with Q&A. Dr. Ghogawala is professor and chair of neurosurgery at Leahy Hospital and Medical Center at the Tufts University School of Medicine. And Dr. Raymond Hah is an assistant professor in the Department of Orthopedic Surgery at Keck School of Medicine, University of Southern California. Just quick housekeeping rules. As we mentioned, the panel discussion will be at the end of our presentations, and please submit your questions via the Q&A icon in the Zoom toolbar. We are also very excited, actually, that our next annual LSRS meeting this year is happening in Chicago, and it will start on April 6th with our instructional course, and then followed by the annual meeting on April 7th and 8th. And we really hope to see you all in Chicago in a few months. So just to start the discussion and our debate and set the stage, there are various parameters that drive the choice of surgical treatment, from patient's history, surgical preferences, to radiographic parameters and changes in the spine. So as we will hear from our speakers, in patients with lumbar spondylolisthesis, usually there are two routes of surgical approach: fusion with or without decompression, or decompression alone. And while patients are often chosen for decompression with fusion based on the perceived instability, when we look at the parameters that drive this choice, there is a large number of literature published papers, but it's still a bit unclear which radiographic parameters indicate the instability and to what level of that instability and how that instability plays when we look at the post-operative outcomes. So quick look at the literature and what's been published in the spine field. When we look at some of those radiographic parameters, here is a summary looking at various spinopelvic parameters, disc height and disc-related measurements, facet joints, and then motion, angular, translational, global range of motion. And several studies have covered those topics. What we've recently done here at USC in collaboration with Dr. Grieco and Hep from Medical Metrics, we were also interested to look at how some of those radiographic motion parameters impact post-operative outcomes in patients with single-level lumbar spondylolisthesis who are undergoing a fusion procedure. And we looked at various radiographic outcomes, including some of the more novel ones, such as sagittal plane shear index. And our main outcome was the pain NRS score at 1 year. So the sagittal plane shear index, just a quick intro to it, is calculated as a z-score from the translation per the degree of motion. And this was a paper published in 2015 that introduced this parameter. And it really actually can help understanding the abnormal translation between flexion and extension. So when we looked at this particular parameter and some others in our patient population and divided them among the ones who had normal SPSI, which is a value less of 2, and the ones who had abnormal, the value above 2, we found that in the ones who had the normal value of this parameter, they had significant improvement, almost fourfold at 1 year in their NRS score. And we did not observe that change in the patients with abnormal SPSI. And while the sample size is obviously small and it requires further expansion, what this shows is that together with the other literature, and we will hear from our speakers, that there are different multiple variables that we have to consider when we are defining instability and looking at the best treatment option for our patients. And with that, I'll turn it over to Dr. Ghogawala and his presentation.
Perfect.
Okay, great. So first of all, thank you so much to the Lumbar Spine Research Society, and in particular, thank you to Dr. Lee and Dr. Buser for inviting this discussion and inviting Dr. Hah and myself to talk about lumbar spondylolisthesis and whether or not we should fuse the spine or not. So I'm going to take the position that the long view, fusion prevents reoperation for the sake of this debate. And I really look forward to a healthy discussion around this topic. And I'm honored to have the opportunity to talk about this and debate this with Dr. Hah. In terms of disclosures, I have some federal funding that supports some of the research that I do, and I have a separate foundational source that helps look at cost analysis, and I have some intellectual property in a commercial entity that's not related to this debate. I'd like to first just acknowledge and thank a number of co-investigators with me, Ed Benzel, Fred Barker, Melissa Dunbar, Jim DeZuria, Subbu Magay, Fred Harrington, and Jean Valerie Kumans, who were the original SLIP study investigators, which I'll reference in this discussion, as well as Dan Resnick, Praveen Mumanini, and Chris Shaffrey, who have helped, I think, develop where we're going forward with this type of topic to understand which patients need a fusion and which patients perhaps don't. So I'll just start out with, I think, the importance of this topic. I think we all recognize that spinal fusion surgery is under substantial scrutiny by multiple stakeholders. We spend $86 billion on spine care in the United States. We do 500,000 spinal fusions per year in the United States at a cost of $12.8 billion in hospital costs alone. And when we consider the increasing rate of utilization of lumbar spinal fusion, 15-fold increase in complex spinal fusion from 2002 to 2007, which has, by the way, increased until now in 2022. We've got to look at this carefully. There are increasing complications and costs associated with these operations. And when you boil it down, and this is data from the SPORT trial, a fusion is about $35,000, and a decompression is somewhere between $10,000 and $12,000 real costs in terms of understanding this from a socioeconomic perspective. So I thought I would just lay this out, and we take data from national statistics. We do about 150,000 operations for lumbar stenosis and spondylolisthesis per year in the United States. And if you look at decompression costing $12,000 and fusion costing $35,000, and multiply it by the way in which we currently treat this disease, where today, based on state inpatient data, as well as from the National Spine Registry, the American Spine Registry, we do about 80% of these cases in the United States as a spinal fusion. One can calculate what we spend. And so 125,000 fusions, 25,000 decompressions. We spend nearly $5 billion on this problem per year in the United States. Now, we'll talk about, and I'm sure Dr. Hah will bring up, that not all places in the world treat spondylolisthesis the same way. In the United States, 80% of the time we elect to treat these patients with a instrumented fusion in addition to a decompression, but in Europe and in other parts of the world, they have a much lower rate of utilization. So if we looked at a possible future state where we practiced like many of our European colleagues practice, where 30% of the patients are treated with fusion, that would be nearly a $2 billion savings in the United States. So the point here and the importance of studying which patients benefit from fusion and which patients perhaps do not is really important, not just from a patient outcome perspective, but is really important to us as a society in terms of how we expend our healthcare dollars. As you know, in 2016, there were 2 randomized controlled trials on the topic of degenerative lumbar spinal stenosis, one from Europe, one from the United States. I was involved in the study from the United States, but the bottom line is that when this was looked at with a heterogeneous study population, as the European study did, there was no advantage for fusion associated with the treatment of lumbar stenosis and spondylolisthesis. When I say heterogeneous, what I mean by that is that the study included both 1 and 2 levels of disease, did not look or examine at some of the points that Dr. Buser was mentioning in the beginning, did not look at flexion and extension x-rays. And so we had a somewhat more limited understanding of that patient population. On the other hand, when we did what was done in the United States study, the SLIP study, we looked at a homogeneous population of patients, single level disease. We did flexion and extension on each of these patients. We only included patients where there was no gross translational instability and no mechanical back pain. And we found the study population matters because when we looked at this homogeneous population, we saw a significant advantage for patients treated with fusion when they had grade 1 spondylolisthesis. If you look at this in a little bit greater detail, one of the conclusions, and I may be sounding like I'm arguing for Dr. Hah's side, but I'm not really. But one of the conclusions I think you can draw without a question is that not all patients with grade 1 spondylolisthesis need a fusion. Okay. However, with the limited knowledge that we have about what patient has what anatomy and what really helps predict delayed instability, as a population, it is probably better to fuse these patients when you don't know whether there's instability or not. It looks like from the data that we generated in the SLIP study, approximately 30%, nearly a third of patients treated with a decompression alone will, within 4 years, and you can see that on that plot, develop delayed instability and need a reoperation to stabilize the spine at the index level of decompression. The challenge for us, I think, as all spine surgeons, is to identify what are the individual characteristics of patients that help us predict which patients are stable and which patients are unstable. I should mention that there's been further work on this topic. There was the Norwegian study that was just published earlier in 2021, designed a little bit differently as a non-inferiority randomized control study looking at single level grade 1 spondylolisthesis with decompression alone versus decompression and fusion. And just to remind you, the Swedish study had shown no difference. The SLIP study had shown decompression and fusion was superior. And so they decided to look at more of what we did with the population in the SLIP study amongst the Norwegian population. And they designed their study to look at 2-year ODI, 2-year change in ODI as their primary outcome measure. And rather than defining this as a superiority study, they decided to look at this from a non-inferiority perspective with a margin of 15 points. One of the things that's important here is that the decompression arm of the study was done with midline sparing. So it was done with a minimally invasive approach where the interspinous ligaments were intact. And decompression and fusion was done with either MIS approaches or with open approaches with interbody devices being optional. Their outcomes, no difference. No difference between decompression alone and decompression and fusion. A 20-point reduction in ODI in both populations, with 75% of their patients having a substantial reduction in ODI of 30 points in both groups. So the Norwegian study really argues for not providing a fusion in patients with this disease. But I would say not so fast. The Norwegian population is different from the American population. One of the things that struck me in looking at this paper is that the overall BMI for patients included in the Norwegian study was much lower than the average BMI in the United States. And I believe the BMI was about 24 in the Norwegian study. Also, reoperations, which I think is one of the tenets of this discussion on whether or not to do a fusion or not. Reoperation was different. The decompression alone had a higher reoperation rate than the patients treated with fusion. But interestingly, and this was pre-specified in their analysis, they excluded patients who had reoperation in their study. And I would argue that reoperations are very important. They're important to our patients. They're important for us as surgeons to understand whether we've been successful in the surgery that we're doing. And they really must be included in the analysis. And I would further point out that had we in the SLIP study excluded the patients who underwent reoperation, we also would have had the same conclusion that there's no difference between the groups. But I think we have to consider what's really happening to our patients. And reoperation is a fundamentally important part of this. So they must be included in the analysis. So I would say at this point, for spondylolisthesis, what's optimal? We've got to consider things from our patient's perspective, satisfaction, outcome. We want to be able to exercise judgment and try to look at these radiographic studies, identify what features we think are important for predicting instability or not. And we also, from a societal perspective, we want to do what's durable. And so what we have done subsequent to the SLIP study is we've tried to do further work to help classify patients into whether they're stable or unstable with grade 1 spondylolisthesis, recognizing that doing a nicely, finely tuned study with a very homogeneous population is nice for the purpose of conducting a randomized controlled study, but that's not reality. We have patients who come in all shapes and sizes, and we need to begin to understand how do we predict which patients are stable or unstable amongst this large heterogeneous type population. So what we've done is we've started a study which we've gotten funding for called SLIP-2. And that's a fusion versus a non-fusion registry for grade 1 degenerative spondylolisthesis with a goal of collecting 1,000 patients over a 3-year period with a complete radiographic capture analysis. And Dr. Buser presented before we got started some very sophisticated analyses of radiographic studies using medical metrics. And our goal is to do something similar to try to decide with the use of experts who review each cases, whether we can develop a cognitive neural network to help us understand how to classify these patients. So we have 15 sites with high volume. Our primary outcome measure is the ODI and EQ5D, and we plan a cost analysis over 5 years. And I mentioned this because I thought I would just share with you some early work that we've been able to get done in this regard. We started with 30 investigators, and not just American surgeons. We include orthopedic surgeons as well as neurosurgeons in this group, as you can see, but also a number of international surgeons. Astrubal Falvinia, for example, from Brazil, Raj Shaker from India, Dr. Kawaguchi from Korea, and a number of international surgeons in this group. And the idea is that, while we as individuals, we can look at individual studies, we can look at translational instability, we can look at rotational instability, we can look at facet angle, for example, disc height. All of these things have been published on. We looked in our SLIP study, for example, disc height greater than 6.5 millimeters, greater than 3 millimeters of translation, facet angle greater than 50 degrees, all predictors of instability. But we just don't know the whole story. We don't know how to predict but perhaps a group of experts might have some crowd wisdom that will help us understand this. So the way that we do it is we take each patient that we have in this study and we give a little clinical vignette, in this case, a 53-year-old woman with pain in the midline, worse when standing, failed conservative therapies. We identify what the diagnosis is. We show these expert surgeons flexion and extension radiographs that they can expand on their iPhone or their personal device, the sagittal T2 weighted MRI, as well as the relevant axial images and the physical exam. And then we have a list of 15 people that are sent these images as part of the study, and they characterize their approach in terms of their preferred approach. In this case, instrumented interbody fusion was the vote by this surgeon, and then the details of their approach. And we try to collate that together. In this particular case, there was motion at the L4, L5 level. There was some facet fluid at that level. And the majority of the surgeons, greater than 80% of the surgeons, felt that they would treat this with a fusion as opposed to a decompression. Now, what does that mean? I'll show you in just a moment. We have right now 575 patients randomized from 14 sites. So we're about a little bit more than halfway through in terms of our enrollment, and roughly half are getting this expert review and roughly half are not getting the expert review. And so one of the natural questions is, does this matter? Our preliminary data suggests that when surgeons are aligned with what the expert panel says, they appear to have better outcomes. Now that suggests that there's some validity in what a group of experts are seeing in the case. But what I think is even more interesting is that we can look at this and say, okay, a majority of surgeons in this study are voting for fusion. 77% of the time we get a majority vote that says we should do a lumbar spinal fusion. In US practice, as I mentioned, greater than 75% of the time, we do a lumbar spinal fusion in these cases. But what I thought was really interesting is that when you look at a super majority vote, that is when 80% of surgeons say the same thing, that to me says it's more likely that a real pattern is being recognized in these radiographs or in the clinical history. In a supermajority situation, 54% of the time, we say that a patient would benefit from a fusion. And so what we're doing now is we're working with our AI experts to develop this cognitive neural network. Irfan Issa at Georgia Tech is working with us and has helped us to try to understand these data. One of the things that's promising about this is that when we look at the supermajority vote on these cases, whether it's for a fusion or for a decompression alone, the outcomes are better than when there is no supermajority vote. And so that again suggests to us that there's some clinically meaningful pattern in these cases. What do we conclude? I think right now, I didn't spend a lot of time talking about various individual radiographic characteristics, because I think while there is data supporting the role of disc height, there's data supporting the role of measuring pelvic incidence, there's data supporting the role of facet shape and facet angle, and data supporting translational instability or rotational instability. We still don't know, despite all of that, how to accurately predict whether a patient is going to develop delayed instability or not. I think a number of us think that we can, but when you look at the data, the reoperation rate is higher than I think we'd like. It was about 33% in the SLIP study. And so when we conclude, we say, you know, there's level 1 evidence to support from a population perspective that decompression and fusion is associated with superior outcomes. Fusion was associated with better outcomes and significantly less reoperation over a 4-year period. When we look at the Nordstrom trial, which excluded the reoperations, they saw similar results for decompression and decompression with fusion, but these were rather short-term results at 2 years. And what we saw with the SLIP study, I think, was that we've got to, when we consider grade 1 spondylolisthesis, we've got to look at the long game. We've got to look over 4 or 5 years if we really want to understand reoperation rate and whether our operations are durable. So I ask you as I close, when you're sitting in your office with your patient and trying to develop trust with your patient, what are you going to do? Do you do a decompression alone, which has a 33% failure rate? Or do you do a fusion, which is what I would argue, where you have better outcomes from a population perspective with durability? I thank you for the opportunity to have this perspective for the debate. And again, I look forward to further discussion with all of you. Thanks a lot.
Thank you. Next, we have Dr. Hah and his presentation on decompression.
You guys see this okay?
Yeah.
Yeah. Beautiful. Well, thanks again so much to both Zori and Michael and LSRS for the opportunity to speak here. Thank you for setting me up and putting me against the world's expert in this space. Zoe, that was a great talk. Thank you so much. And, you know, I think at the end of the day, you're going to see some of the same studies, some of the same words and some of the same challenges, I think, as we navigate what is really the best decision for our patients. So I'll be taking the side of decompression without fusion is the way to go. Don't be afraid of instability. I don't have any relevant disclosures to this particular talk. I'm a consultant for NuVasive and get research support from SI-BONE. We all know, you know, the landmark studies, I think, which have shaped a lot of our education as spine surgeons in 1991, Herkowitz, and then, of course, the subsequent follow-up in regards to instrumentation, demonstrating that in patients with spondylolisthesis and stenosis, the outcomes were better when a fusion was done. Now, an instrumented fusion did not necessarily show the same clinical benefit, but certainly improved fusion rates, speaking to overall durability. But we know, as Zoe mentioned, you know, this is a real issue as fusion rates continue to rise, and cost containment for different countries are important. And fusion rates really do differ by country. In the European, some of the socialized medicine countries, you see utilization rates of fusion in between 30 and 50%. And again, much different practice patterns up to 80 and 90%. And whether that's influenced by reimbursement or education or patient expectations, cultural expectations, remains to be seen. But it's really important that the work is being done there and should be applauded. So we know a few things. When it comes to this topic, spondylolisthesis is heterogeneous. We know that decompression is also heterogeneous, the technique used. We know that fusion has a higher major complication rate and cost. And overall, the US experience to treat this pathology has had a tendency, at least, towards fusion. To get a little bit off track, I just want to give some corollary examples in which, you know, we accept a certain level of failure in attempts to spare a patient of the morbidity of fusion. And, you know, it's not exactly comparing apples to apples, but let's take two similar clinical situations. In the setting of a synovial cyst, decompression alone, and a revision microdiscectomy for recurrent disc herniation. So this was a study in 2010 looking at 966 patients who underwent a decompression of a synovial cyst, and around 20% had recurrent back pain, and 6.2% of patients required reoperation. Now, obviously, in the literature, this number varies, and some studies report up to 25% rate of recurrence or more. These revisions were primarily done for instability and back pain, yet I don't think that most surgeons would hesitate to decompress a synovial cyst in the absence of overt instability after careful discussion with the patient. I think that it's reasonable. This was a study that we did out of USC looking at revision rates after revision discectomy. So we initially followed a single level lumbar discectomy cohort for 2 years. Then around 4.5%, a little more than 4.5% underwent a recurrent revision discectomy. And we followed those patients for additional 4 years for any additional lumbar intervention. And actually, soberly, up just a little under 40% actually ended up undergoing subsequent fusion within the 4 years of that reexploration revision discectomy. So again, I ask, with these numbers and fairly high rates of revision, why is it that we're willing to, again, take the chance with the patient to spare them the morbidity? And I think in some ways, we're maybe a little more afraid of instability than other pathologies for maybe unclear reasons. So we're going to just take these cases point by point, spondylolisthesis and surgical technique, and then just drilling down a little bit on the literature, which Zoe covered fairly convincingly. So we all know that there are various factors in regards to what may predict instability after decompression. Disc height, facet tropism, fusions, local and global alignment, as well as the etiology of stenosis. This is a patient in which groupthink I think would be very helpful. You have a patient who has a fairly collapsed disc, not moving much from supine MRI to standing X-ray, a fairly mild slip overall. The right facet has significant fluid and has sagittal alignment. The left facet is fairly reasonable. And most of the stenosis, again, is coming from hypertrophy of the facets and ligamentum flavum hypertrophy as opposed to instability causing the stenosis and claudication. And so in this patient, I think if you could go certainly either way. This is kind of an in between. And it just goes to show you that there is not a black and white, and certainly we'll look to the literature to guide us. Well, I think that some investigators have done a great job in terms of trying to advance the way that we look and think about the granular details of spondylolisthesis. The CARDS classification by Kepler and colleagues categorize these into 4 subtypes. Type A with advanced disc height collapse but no deformity. Type B with some amount of motion with the disc preserved and less than or more than 5 millimeters of translation. And then type D, which factored into segmental kyphosis and issues with alignment. Now, further work needs to be done to see certainly if this can be applied to the way that we look at future studies, but I think it's at least a good framework to look at not just 3 millimeters of slip being a degenerative spondylolisthesis, but there being various subtypes which act in different ways. Moving on to the heterogeneity of decompression, we know that from several cadaveric biomechanical studies as well as finite element analysis that a standard midline decompression with medial fascectomies as opposed to a unilateral fenestration or unilateral laminotomy for a bilateral decompression, and even to a greater extent endoscopic decompression is going to come with different levels of destabilization. And that's very important to note as we look at each of these individual studies, as a decompression is not the same. We're not comparing the same things. I thought this was an interesting study looking by Keller and colleagues. They looked at a unilateral laminotomy for a bilateral decompression in a group of patients. They categorized their patients into stenosis without instability, spondylolisthesis only, and scoliosis, and combined scoliosis and spondylolisthesis. And what they found that with a pure spondylolisthesis patient, they really only had a 4% rate of revision in terms of subsequent instability. And some of the additional risk factors which they drilled down upon were really lateral listhesis and olisthesis. Even more striking was this endoscopic study out of Japan. They had 304 consecutive patients with single level degenerative spondylolisthesis and stenosis. They did an endoscopic bilateral decompression, so arguably the least amount of tissue disruption. And they found a very low rate of revision, 7.8%. One thing that was very interesting about the study is that as they longitudinally followed these patients, they identified a cohort in whom had initially had instability, but as the natural progression of disc degeneration and spondylosis progressed, they actually subsequently stabilized. And that they hypothesized that by preserving the posterior elements as much as possible, this allowed enough stability for the natural progression of the disease to occur. And the question of durability is, given enough time, will all spondylolisthesis continue to slip, or is this natural progression towards stability? And this study certainly raised this question. When looking at a bird's eye view at a population level, maybe a little less helpful in our individual practices, several meta-analyses have looked and showed no difference in VAS, ODIs, EQ5D between decompression and fusion. Really a trend, but really no differences in complications, and ultimately no difference in reoperation. What has been well established though is that if you fuse someone, it will take longer in the OR, you will have larger EBL and a longer length of stay, and additionally cost by corollary. This was another meta-analysis with a slightly different focus. This was purely grade 1 or mild degen spondy cases were included. They looked at 12 studies with 591 patients, and over the range of these studies, again, they found no difference in patient-reported outcomes. There was a higher rate of complications in the fusion cohort and a lower rate of reoperation in the decompression, in the fusion cohort, as Zoe had alluded to. Drilling down on the few very important individual high-level evidence studies. I'm not going to go into great detail, of course. You know, when you look at this particular study, I agree, very homogeneous population. They excluded any patients with instability, so stable spondylolisthesis between 3 and 14 millimeters. But really important is that the decompression treatment of choice was a standard laminectomy with bilateral medial-fascectomy. So potentially the most destabilizing of the decompressions. And that perhaps may be part and parcel why the revision rates perhaps were so high in the decompression cohort. And it would be an interesting question to see, you know, if technique would make a substantial difference in those outcomes. The other interesting thing to note about reoperation rates are of course, index instability making up the large percentage of revisions for decompression alone, but ASD, including instability and stenosis, made up by and large the revisions for instrumented fusion. And you know, if you do extrapolate over time, although your instability rates based on that previous study I mentioned may actually stabilize, ASD rates certainly given over time would actually increase. And so if you follow these over a large and long time period, I think that these numbers would actually come closer together based on some of the information that we have. Just to briefly mention the other study that was in the New England Journal of Medicine, the same issue. This again was not a specific cohort. These were initially patients with stenosis, and there was a subgroup with spondylolisthesis. They defined this as purely static x-rays, and about half were fused and half were decompressed. They didn't find any difference overall in any outcomes, but what they did find was that the reoperation rates of patients with spondylolisthesis were actually about the same over their study period, 22% in the fusion and 21% in the decompression. If you go to the appendix, I think this is also a very telling table, I think a very important one. True, the decompressions will have restenosis and potential foraminal stenosis. I think this is a result of knowing which ones are unstable or not. But in the fusion cohort, adjacent segment stenosis and pseudoarthrosis equaled kind of the decompression cohort. So again, the issue of reoperations and durability may not be as black and white as we think as well. This was another study out of Japan by Inose et al. And they had a single center prospective randomized study in which they randomized patients to laminectomy and fusion, and then laminectomy and dynamic stabilization. They defined their cohort of spondylolisthesis as greater than 3 millimeters of slip on the standing lateral. Again, no characterization of instability, no use of dynamic x-rays, and no categorization of risk factors. But overall, again, on the population level, they found that there was no difference in the lumbar LJOA, the VAS, low back, or leg pain, and certainly higher complication rates in the fusion and even in the stabilization group. I'm also going to spend just a brief amount of time on this newest study, as Zoe mentioned, out of the Nordsten DS investigators, published in 2021. They included patients from 18 to 80 years with claudication or radiculopathy, single level spondylolisthesis and stenosis, and again, defined it on static lateral radiographs. They excluded foraminal stenosis, previous surgery, former fracture or fusion. In this case, the decompression group was a midline sparing unilateral decompression, and the fusion was decompression of any technique, as well as pedicle screw fixation plus or minus interbody fusion. And if you take a look at these groups, really equal percentages reached MCID for ODI, and there was a non-inferiority margin. I think the point is important. They were not powered to compare reoperation rates. The decompression had a slightly higher reoperation rate. Interesting also to note would be what happens as they go to 4 years, 5 years. Are the survival curves for each of these surgeries going to more closely approximate themselves as the ASD and adjacent segment instability rates go up? And the most important information, which was not reported, maybe the subgroup analysis of those that did not reach MCID. Why do people not get better in either cohort? So in conclusion, I do think that at a population level, decompression compares very favorably to fusion for degenerative lumbar stenosis, lumbar spondylolisthesis. I think I agree with Zoe. The studies provide a population or overview level recommendations, but not the individual. When we have blanket statements for any of these things, I think there's the potential for both under and over operation. And really future studies, as Zoe is working on, should focus on identifying subtypes most at risk for instability and seeing who will most benefit from a more invasive intervention at the offset. Thank you.
Great. Thanks, Ray. Thanks, Zoe. Those are fantastic talks. This time, I'd like to invite our participants to submit any questions to the Q&A. I'll get started with some questions while people are submitting theirs. Ray, you mentioned some heterogeneity of technique of decompression. So if you have someone with a grade 1 slip that you're not going to fuse, what kind of surgery are you going to do? Are you doing just a midline sparing laminectomy or bilateral laminotomies? Is there an optimal procedure that we should do to minimize the likelihood of developing instability afterwards?
Yeah, I do think that obviously getting the pathology is most important. So it's comfort with technique. I would say, at least in my practice, these patients who get decompressed, it's a unilateral laminotomy with a bilateral decompression, saving the contralateral lamina as much of the posterior elements as possible.
Should we be doing an open traditional laminectomy on these patients? Or is that just going to ask for problems? Are you just kind of playing with fire?
I personally think we shouldn't, but I think it's also comfort with technique, and there's a significant learning curve, certainly to MIS techniques. I think that the pendulum is going to shift towards really people treating these with tubular and even down the line potentially endoscopic decompression.
Zoe, how much do you think conflict of interest affects our decision making for those tweener patients where you can kind of go either way? And I don't mean conflict of interest with device companies. I mean just any surgeon who's in an incentivized compensation model, whether it's RVU based or collections based, is going to do better for him or herself by doing a fusion than doing a decompression. How much do you think that kind of plays into our national psyche or decision making on a national level for 80% fusions, across the United States for these diagnoses?
Yeah, I mean, I think, that is a very, very key issue. I think that's a very, very key issue. I did an interesting experiment in my department along those lines because I was very interested in this. And so I thought that, rather than having our department completely incentivized around RVUs, that we would put an incentive metric for all spine surgeons that was on health-related quality of life gained. And I thought to myself, let's take a look at our fusion rate and what we do as a practice with an RVU-based model, where surgeons are going to make more by doing procedures like fusions that have more RVUs, and then look and see if you change the incentive model for surgeons to generating more health-related quality of life, what happens? And what I observed was that multi-level fusions decreased in the department when we went to a health-related quality of life model. Single-level fusions did not, interestingly enough. And I think that there's something that is ingrained in our psyche around grade 1 spondylolisthesis being treated with a fusion that is pretty firmly embedded in people's minds. And I think having these types of discussions is important because not everybody necessarily needs to have a fusion in these cases. And having our incentive models be designed a little bit differently might help see a change in that practice. So I think it is a factor. We can't, I think, escape it, but it's not the whole story.
Thanks. We have a question from Trey Crawford from Norton Leatherman Spine Center. I'm just going to read his question verbatim. Great presentation so far. Looking forward to the discussion. In my experience, some decompression-only patients will develop recurrent stenosis, especially with multi-year follow-up. Do you think this is an indication? Do you think this indication for reoperation has different risk factors for post-op instability?
I think yes. I mean, I think that, there's so much that we don't know and that we don't understand. But in a sense, these patients who have a decompression alone and develop recurrent stenosis at that level are not that different from the patients who develop adjacent level stenosis when they're treated with a fusion, right? There's some elevated degree of motion at that level, presumably, that results in more ligamentous hypertrophy and, as a result, symptomatic stenosis. So I do think that that's a factor. The problem, I think, is that we just don't know how to predict which patients are going to have this type of response to our surgery or not. And I think that, having better classification schemes that are based on larger volumes of data is ultimately going to be what we need. But right now, I think we're just not very good at it.
Ray, what do you think?
Yeah, I would agree completely. I mean, I think there's, a phenotypic aspect to it. People, it's the same as you fuse somebody, they have adjacent segment instability, you fuse them, you chase them up the spine, even if they have good alignment. I mean, there's some people whose connective tissue breaks down in certain ways. And I certainly think there's, a wealth of research to be done in that, beyond even radiographic measures and those kinds of things, but actually patient factors and genetics. So that'll be interesting going forward. But it's true. I think to another point is, how much decompression is enough. There is that trade-off. You do a lot, maybe they won't recur, but you have a greater risk of destabilizing them. Where's that sweet spot? And, I think, frankly, that's probably the hardest part of what we do, knowing when kind of to stop or when enough is enough.
Yeah, especially if they're unilaterally symptomatic but have bilateral stenosis. And do you chase the other side? Is it really worth it? A lot of questions that remain unresolved. Another question from Trey Crawford. It's a little bit outside of spondylolisthesis, but let me ask the panel. Is severe foraminal stenosis always a contraindication to decompression only? Meaning, does severe foraminal stenosis require complete facet resection and interbody device insertion? Ray, why don't you take that one?
Yeah, I would say no, but I think it's also in carefully selected patients. Obviously, probably one of the most overutilized indications for fusion is severe foraminal stenosis and iatrogenic instability. You know, I think there's a growth of techniques which can serve to address that. You know, a unilateral tubular addressing the contralateral side, you can really get out into the foramen and do a pretty extensive decompression. I think, you know, transforaminal endoscopic surgery, you know, potentially is a game changer. That's the main reason why I would want to pick it up. You know, in a patient with, you know, maybe a fractional curve who has stenosis, but really you don't want to take them for a big scoliosis operation. I think that you can address it. The question though becomes, how durable is it? You know, is it foraminal stenosis, which is going to continue to progress? Are we temporizing? And, you know, the secondary question is temporizing okay? You know, we treat with injections as a temporization for surgery. You know, is the burden of an endoscopic decompression or a tubular decompression really so high that it's not a reasonable temporizing solution before something more drastic?
Zoe, any thoughts?
Yeah, I very much agree with what Ray said. I think that the bottom line is that foraminal stenosis per se is not an indication for fusion. It depends upon the surgeon and what he or she is most comfortable with. I think the tubular retractors have allowed us to do a better contralateral foraminal decompression than perhaps we were able to do before. But I think that the ability to do a good, satisfactory foraminal decompression without destabilizing the spine, without removing too much of the facet joint, is an art that a lot of us are now more focused on. And Ray's right, as endoscopic techniques become more prevalent, I think we're going to get better at foraminal decompression without destabilizing the spine.
Yeah, I think I agree with both of you. I think it's a tough question in that I used to do only foraminal decompression only for foraminal stenosis. And I did notice there was a good number that would come back because of the up-down component of stenosis as opposed to the front-back stenosis. So I started paying attention to that more. And for that reason, I've done some fusions for foraminal stenosis, particularly at L5S1. I remember it is a nuanced skill to decompress alone circumferentially around the nerve root to get the up-down stenosis out of the way. I remember I think Henry Bowman used to do a out part of the pedicle just to kind of make more room in the up-down direction as opposed to front-back. So I think there's a lot of factors around foraminal stenosis, just as there is around spondylolisthesis that we don't fully get.
Your point about L5S1 is spot on. I think if there's an area where I struggle more with satisfactory foraminal decompression, it's at 5.1, and I'm more apt to recommend a fusion in those cases.
Looks like we have a question in the chat from Rohil Chauhan. Thanks for the presentations. What are your thoughts on addressing concurrent symptomatic discogenic pain without leg pain with the grade 1 spondylolisthesis?
So axial back pain with grade 1 spondylolisthesis without root symptoms?
That's what it appears, without leg pain, correct?
Yeah. So I don't know honestly about the discogenic nature of the pain, but I think that if you have a patient with grade 1 spondylolisthesis that has evidence for mechanical instability, change with angulation with flexion and extension, translational instability, or signs that there's some unstable component of this spondylolisthesis, even without nerve root pain, I think those are good candidates for stabilization. I'm just not sure that I know how to diagnose the discogenic nature of the pain in these patients. But if there's radiographic evidences for instability, I think that they should be fused.
Ray, your thoughts?
Yeah, I think at least in my practice, it's pretty rare that a patient will be offered a fusion purely for the back pain component of a spondylolisthesis without concomitant neurogenic symptoms. I think that's always going to be difficult. I do agree, as they're increasing radiographic signs of instability, it maybe becomes more reasonable. I think the real hard question in my mind is somebody who has a stable slip, not a lot of motion, but a severe amount of back pain. How much will they benefit actually from fusing and stabilizing that? And I think we definitely don't know the answer to that.
Yeah, back pain is the bane of our existence. It's hard to know if that's spondy's even causing any back pain at all. So you and I kind of started talking about this before the actual webinar, but and Ray, I'd like for you to comment as well. How do you guys counsel patients when you have a tweener patient, someone that you're just not sure about? How do you go? What's your process in counseling a patient on the direction that you recommend, and just for younger viewers right now?
Sure. Maybe I'll take that first. I think that's really ultimately the key around this discussion, is that I think probably all in this group agree that not all of these patients need to be fused, but there's a lot of tweener patients where we just don't know. And as much as we think we can focus in on one aspect of things, we really don't know. I've got lots of patients that have 4 or 5 millimeters of motion on flexion and extension, have no mechanical back pain, and I've done a decompression alone on them. I have 5 to 10 years of follow-up, and they've done great. So there's just aspects of this we just don't know and understand. What I tell patients is that the data on this suggests that a majority of patients treated with a decompression are going to do fine with durable results. But somewhere between 30 and 40% are going to get symptoms of instability and back pain. Not all of those will necessarily need a reoperation, but they're going to get symptoms of back pain that might be more significant than what you have today. So you'll have a new type of pain, and either we'll be able to manage it with conservative measures, or we'll need to ultimately do a fusion. And so I ask patients this, is that if you're concerned about the need for a second operation, we should just do a decompression and do a fusion now. We'll use a minimally invasive technique. We'll get you out of the hospital in a couple of days at the most, and most patients do well. But on the other hand, if patients feel like, I really want the smallest operation possible, and I can accept a delayed operation in the future, then I think that's a very reasonable strategy, and I support patients in that.
Right.
Yeah, I'm the exact same. That discussion is very transparent. I go over some of Zoe's data. I let them know, it just depends on your philosophy. If you're the type of person who says, hey, I want to be in there and fix it all, and give me the best chance of, then we go for the full deal. And to make one point, I do think that the gap between complication gap between fusion and decompression is certainly shrinking as well. I think with MIS techniques, and you think of true indirect decompression, lateral and posterior percutaneous screws. That patient is home the same day. There really is a decreased burden even of some fusion techniques. I think that the question always becomes, do you accept your reoperations early, or do you accept them late? There's a certain nihilistic aspect to it, because in the end, either adjacent segment disease or something, the spine keeps deteriorating. So I always leave it up to the patient. I get a sense of their philosophy. I usually try to talk about it in terms of layperson terms, like you go to the mechanic, 5 things wrong. Do you want to just kind of patch it up and keep going, or and involve them in that decision?
Yeah.
So as a quick, oh, sorry, Mike.
Go ahead, go Zoher.
as a quick follow-up question, so obviously defining instability on all those radiographic variables that we've discussed, but then what if some patient risk factors, like some of the studies looked at, BMI, bone density, depression, you have a patient who has maybe a list of those risk factors, does that changes the approach that you will take for surgery?
Yeah, I think, Zori, those are very, very important aspects. I counsel patients that significant obesity is a risk factor for surgery in general, but is a risk factor for delayed instability. And that if I think it's reasonable to do a percutaneous instrumented fixation and minimally invasive fusion on an obese patient, then I'll tell them that, I think in your case, it might just be better to do this upfront now and not take the risk of delayed instability. Depression, I think, factors in very well. There's some very interesting work being published on depression and spinal surgery. And one of the things that's caught my eye in this area is that many patients who are depressed can substantially benefit from a fusion if they had mechanical symptoms of instability at the time. And so just per se, the diagnosis of depression does not necessarily mean that they won't do as well from a fusion operation. And so I think that also becomes a more of a nuanced picture. So I try to get a better read on somebody if depression is the issue. Multiple medical problems, as you raise. I think what Ray said about the gap between MIS fusion and decompression alone surgery is narrowing. And so it's allowing us, at least at the single level, to treat a patient even with multiple comorbidities successfully with a MIS single level fusion. So that has not entered in my calculus as much.
Yeah, I would agree. In general, I think obese patients certainly are at risk for delayed instability. Unfortunately, by corollary by adjacent segment disease after fusion. So, I think if at all possible, medical intervention, optimization in that regard, if they're able to, tolerate that is appropriate. I think osteoporosis or the elderly, I would say in my practice, at least, I have moved towards maybe a more classical treatment algorithm, doing more limited decompressions. And if I'm really worried about instability, doing in situ fusions and bone only fusion, I think that, especially for the above 80 patient, I mean, they do very well, so definitely important as the radiographic.
Let's end with one last question from Trey Crawford. Any comments on when it's appropriate to offer a patient a reoperation? Presumably for the decompression only kind of situation. So let's say you do a decompression only, maybe the slip obviously doesn't get any better, but they have recurrent symptoms. Ray, what do? Do you sit on them for a while, see if they kind of auto-stabilize like that one study suggested, or what's your approach to those patients?
I mean, I think it depends obviously on the severity of symptoms and the amount of disability they have. I mean, I truly don't like doing an early reintervention simply based on the disruption, unless there's, overt progression or neurologic symptoms or anything like that. I think it's reasonable to try to let them cool down and stabilize them if they need medication, if they need, injections or anything like that, to see if it'll calm down. I don't really have like a time point, but I do base it on severity of pain. And if the patient is really suffering, then I'm not going to make them wait.
Great. Well, it is a little after 8 o'clock. I want to thank everyone for being a part of this webinar. Thank you. Thanks to our audience for sharing their evening with us. Thanks to our two great speakers. This is fantastic. A lot of questions to be asked, a lot of things to be discussed. We haven't nailed this for sure, but I appreciate you being here for this discussion tonight. And just a reminder to all of our audience, Lumbar Spine Research Society is April 6th to 8th, so please look into that. We'd love to have you there. Thank you and good night.